I have been given this opportunity to introduce a great stalwart in orthopedics, Dr. Raju Vaishya. He did his initial education MBBS and MS Orthopedics from Gwalior, and then he did his MCH from Liverpool in 1990, from Liverpool University, England, and FRCS in 2012 from Royal College of Surgeons of London, UK. He has, there's a long list of achievements to his credit. I will read some of them. He is president of Indian Cartilage Society and Arthritis Care Foundation, and he has a world record. He's a world record holder. He is listed in Limca and India Book of Records 4 times for doing bilateral total knee replacement in oldest person and couple at the age of 93 and 86 years. So, clapping for him. He has numerous publications, more than 350 in international and national orthopedic journals based on clinical work and research. He is a pioneer in using 3D printing patient-specific instruments for TKR and cartilage transplantation in India. He is a recipient of several distinguished awards like Dr. B.C. Roy Award and Gold Medal for MPIMA, Siemens Gepio Award, and Distinguished Researcher Award in AHERF. He is past president of Indian Cartilage Society and president Arthritis Care Foundation. He has been awarded the Best Paper Publication Awards of Delhi Orthopedics Association and Apollo Group of Hospitals on many occasions. He is editor-in-chief of Journal of Clinical Orthopedics and Trauma and on editorial board of other reputed journals like Indian Journal of Orthopedics, Apollo Medicine, etc. He is also a chairman of IT and Web Resource Committee of Indian Orthopedics Association. He has been a reviewer of many reputed international journals like Lancet, Journal of Bone and Joint Surgery, JOSR, IJO, BMJ, etc. He has special interest in knee surgery, 3D printing and joint preservation techniques. So over to Dr. Raju Vaishya.
Good evening, friends. At the outset, I must thank Physician Forum and especially Dr. Chuan for giving me this opportunity to be with you again. And after a brilliant talk on robotic surgery by my colleague Dr. Nagpal, I will be presenting a very basic talk on a very common problem that we almost all either are suffering or one of our family members has been inflicted with this problem, that is the knee osteoarthritis. It has been seen the biggest determinant for patients not consulting super specialists with knee pain is the fear of surgery. And to be very honest, the surgery is required in only 2% of the patients who have knee pain, and if they are treated in time, the surgery either can be avoided or at least postponed for many more years. And that's what we are going to share today, that how we can postpone the surgery for knee pain, what are the different techniques and methods that are available to us, and if it comes to surgery, what is the solution for it. So the treatment for knee osteoarthritis or knee pain could be divided into mainly three groups: medical, surgical, and now there is another group called regenerative medicine. We did this paper some years ago on non-operative management of osteoarthritis, and the message is very clear that not all osteoarthritic patients require surgical treatment. The treatment is only palliative, it is not curative, and it aims at reducing pain, improving joint mobility, and limiting functional impairment of the patient. And it can be achieved by both pharmacological and non-pharmacological means. And it is, the non-operative treatment is usually very useful in the early stages of this disease. However, in advanced stages, surgery may be required. The most important thing for any chronic disease with which a person is inflicted is the patient education. Whether it's osteoarthritis, diabetes, hypertension, or anything, if person has to live with this disease for many years, he must be educated very thoroughly so that he can live very comfortably and he knows what are the options available to him. And lifestyle modification is one very important aspect of management of knee osteoarthritis. If you modify your lifestyle to some extent, like if you have knee arthritis, if you avoid sitting on ground, if you avoid Indian types of toilet, if you avoid using stairs frequently, avoid standing for long hours together while cooking, etc., especially for ladies, that tremendously helps and reduces the requirement of any painkiller or other treatment. Physiotherapy is of paramount importance because if you have any knee disease, the most common thing that happens is the atrophy of the muscles around the knee joint, especially the quadriceps muscle. And the muscles around the knee joint are the key to the success. If you develop these muscles, they can protect the joint and they can either relieve the pain or postpone the need for further treatment. Nowadays, several types of knee braces and supports are available which can protect your joint or offload the joint by transferring the weight of transmission from the deceased compartment of the knee to the center of the joint. And these braces are known as offloader knee braces, which are now easily available in India and quite light and good in quality. Non-steroidal anti-inflammatory, however, remains the most commonly used means of treatment for these patients to relieve pain. You know about non-steroidal anti-inflammatory agents than I do, because most of you are physicians. There are several types of non-steroidal anti-inflammatory drugs that have been tried for the relief of pain in knee osteoarthritis. The most simple one is a paracetamol. Along with paracetamol now, tramadol is also used. But unfortunately, it is safe, but it is not as effective in the relief of pain because the inflammation that is associated with osteoarthritis is not addressed by these two drugs. And hence, non-steroidal anti-inflammatory drugs are the most commonly used drugs for the relief of pain in these patients. Previously, we used to use non-specific non-steroidal anti-inflammatory like Brufen, diclofenac, etc. Then came about 15-20 years ago COX-2 specific inhibitors, and we thought, we got something magic now, and these drugs are without any side effects, quite effective for relief of pain, and we might have conquered the osteoarthritis type problem. But then later on, soon after, about 5-7 years ago, later, we realized that patients who are taking COX-2 inhibitors like rofecoxib, etc., are associated with very high incidence of heart attacks and cerebral strokes, to the tune of 4 to 5 times than those patients who are not taking. So these drugs have been, most of these drugs have been withdrawn and they are not being used. Now, since NSAIDs are very commonly associated with high acid production in the stomach, these are now sometimes mixed with PPI or misoprostol. I must emphasize here, I will take 1 minute more, that please do not prescribe more than one non-steroidal anti-inflammatory in one prescription. It is not uncommon to see in our practice that patients having 3 or sometimes 4 non-steroidal anti-inflammatory prescribed together in one prescription, because one was not working, the second was added, then the third was added. But now it is very clearly shown by research that mixing more non-steroidal anti-inflammatory together does not increase the potency for relief of pain. It only increases the toxicity proportionately. So if you have 4 NSAID in one prescription, you are likely to have 4 times more toxicity of these drugs rather than the potency. So the trick is, if you are suppose giving a patient 75 milligram diclofenac in a day and patient is tolerating that but not getting enough relief, you may increase to 100. You may increase to 150 also to the safe limit. So you may increase the dose of that non-steroidal anti-inflammatory rather than adding one more anti-inflammatory drugs, because these drugs are very toxic, especially if taken in long term. And the most important toxic effect that we see in our practice is GI problems, and second is nephrotoxicity. And especially with COX-2 inhibitors, cardiac and cerebrovascular accidents are also seen quite frequently. So please do not prescribe non-steroidal anti-inflammatory to any patients for more than 10 days. You must try it, because once you have written any painkiller to this patient goes and buys this for years together from the chemist, and ultimately they get the problem. So in my practice, I do not prescribe any anti-inflammatory for more than 10 days and then write 1 SOS. So this is the most important message that I am giving from today's talk. The other group of you can say medicine, these are not medicine, these are nutrients that are called nutraceuticals. These substitutes or natural products are helpful in the treatment of osteoarthritis, especially in the early stages. And most of these nutraceuticals actually come from our kitchen. Most of us have plenty of things in our kitchen which are quite useful for our health, and probably that's the reason our ancestors used to use these for various types of health problems, including arthritis. The most commonly used, I will discuss what are the different nutraceuticals that are available commercially now for our use for the treatment of osteoarthritis. There are several types of local application of gel, spray, etc., which are quite useful in relieving pain of osteoarthritis, although they may not modify the disease process, but they are not harmful except for some patients where the patient may be allergic. These usually contains non-steroidal anti-inflammatory along with methyl-salicylate or capsicum to act as counter-irritant and relieving pain. Those patients who do not respond to the above treatment can be offered intra-articular injections in the knee joint. If the patient has an inflamed joint with a lot of fluid inside, the best treatment is to aspirate the joint and to give steroid injection. Steroids are wonderful drugs in resolving inflammation, but they have to be used very carefully and very occasionally. I have seen doctors prescribing 3 course or 6 course of repeated injection after every week. This is a very bad practice, because it has been seen that steroids can damage the articular cartilage if you repeatedly use these injections. So it is also seen that first injection of steroid usually helps for 6 weeks, second injection helps for 6 days, and third injection, first injection for 6 months, second injection for 6 weeks, and third injection only for 6 days. So the potency of steroid in relieving pain and inflammation decreases if you abuse it and repeatedly. So do not use steroids again and again, but they are quite useful in inflamed joint. Another type of injections that are very commonly used are hyaluronic acid. It is also known as viscosupplementation, because these injections are gel-like and viscous in nature, and they replace the synovial fluid and helps the synovium to produce normal type of synovial fluid that lubricates the joint. And usually these injections are helpful from 6 months to 2 years, and these can safely be repeated if required. Very recently, another type of injections that are commonly used are PRP, platelet-rich plasma, which is including joint pains. There you take the patient's own blood, centrifuge it, and separate the platelets and inject the platelets into the joint. Platelets have a lot of growth factors, and it is expected that these growth factors tend to help the degenerate cartilage to grow something normal and normal synovial fluid. The effect of PRP again tends to last for about 1 to 2 years. As I mentioned before, we have a lot of nutraceuticals now available for our use for osteoarthritis, and the most commonly and the most effective is the extract of curcumin, the curcumin extract that is also available in the capsule form. Haldi we commonly use in our food, but the quantity of haldi that we can take is very little, because it is gastric irritant and it tastes bad in large amount. So second problem with haldi is that it is not absorbed very easily from the stomach, and hence now with special technology, nanotechnology, you can give curcumin extract in oil type of preparation in a capsule form, and that is very, very effective. But some patients, about 5 to 8% of these patients, may have GI intolerance, and those are not suitable for them. Then another thing which is quite helpful is ginger. If taken in adequate amount, collagen peptide, glucosamine, aflapine, boswellia, green tea, fish oil, etc., etc. So you can see most of these things are actually available in our house for our use, but the quantity in which we need them for therapeutic use is not met with eating only. So nutraceuticals may help to relieve pain and improvement function in osteoarthritis by suppressing pro-anti-inflammatory agents. These are generally safe, but some people can have GI intolerance. But the problem is that optimal doses, duration of therapy, and right formulation are still not known for most of these things. And these are quite okay to use along with some other treatment like physiotherapy and sometimes occasional non-steroidal anti-inflammatory and injections. As a stand-alone therapy, this may not be effective for long term, and they are very useful in early to moderate stage of osteoarthritis. As I mentioned before, when you have run out of the options from conservative treatment, you have to go for invasive treatment, and semi-invasive is injections, which we have discussed before, Arthroscopy used to be very common operation for osteoarthritic knee. Actually, I learned arthroscopy in England or mostly on osteoarthritic knee, but it has been recently found in last 10 years that arthroscopy for pure degenerative joint disease is not a good option. Only in patients where there is mechanical blocking, recurrent effusion, or something is blocking in the joint, arthroscopy should be done, otherwise not. In younger patients, because we see now osteoarthritis in 40-45 years of age of patients also, they tend to get angular deformity like bow legs or knock knees. And once they get this deformity, the weight transmission is localized to one compartment that degenerates fast. And you don't want to do knee replacement in such a younger age because artificial joints have their own life and problems, and hence you need to correct the alignment of the knee by doing corrective osteotomy, which can restore the center of the joint or center of the weight bearing through the center of the joint, and that usually gives patient pain relief for about 10 to 15 years. So when the patient becomes older, then they can go for joint replacement surgery. Those patients who have very advanced disease come late, and especially in elderly patients, you may have to perform total or partial joint replacement depending on the involvement of the knee. There are now regenerative treatment options available apart from that injection of PRP and hyaluronic acid. If younger patients have post-traumatic cartilage damage leading to osteoarthritis, or osteoarthritis where only part of the joint is involved with localized or focal damage, you can also do cartilage transplant. In cartilage transplant, you take the cartilage of the patient by arthroscopy, grow it in the lab, and then re-put that chondrocyte cells into that defect after about a month, once you have enough growth of the cartilage. And that regrows and saves the joint from getting osteoarthritis and avoids the need of joint replacement, especially in young patients. As I mentioned before, PRP is a cocktail of highly enriched platelet cells, which are normally more than 4 to 5 times of the normal platelet concentration in the blood, and these contain bioactive proteins which helps in accelerating the healing process in the joint. So these injections are quite effective for about a year. The PRP is slightly superior to hyaluronic acid, but in some patients there may be some pain on the day of injection. We have also done a comparative study on the steroid, hyaluronic acid and PRP injection in Apollo Hospital, and we found that steroids give you the immediate relief of pain and inflammation, but their effect tends to wane off after about 6 weeks or so. Whereas hyaluronic acid gives you relief in a couple of days and effect tends to sustain for about 6 months to 1 year, whereas PRP is slow to take off in terms of pain relief, but its effect lasts for maximum time for about up to 1 to 2 years. As I mentioned before, we also have the option of cartilage transplantation, and this is a very promising surgery for patients who are young and who have localized defect in the cartilage, because it can postpone or alleviate the need of prosthetic joint replacement in future. There are various other types of surgery which we do to preserve the joint, and I am not going to bore you with the various surgical techniques of these. But there are several options that are available. You can simply make bone holes with microfracture technique in the deceased cartilage lesion, and that tends to regrow the cartilage-like structure and protect the joint. This is how, after articular cartilage transplantation, you see the white structure that has regrown on the bare bone. It is now possible to do cartilage transplantation in single stage. Previously we used to do it in 2 stages, where you harvest the normal cartilage, regrow in the lab and then re-put. But now, under carbon dioxide insufflation arthroscopic technique, you can do this in 1 stage, and that is quite possible, which has been described by Kim and Chetty from London and South Korea. High tibial osteotomy in younger patients who have deformity is also a very promising procedure, which tend to give 15 years or so life to these joints. Those who have severe disease where joint replacement has to be done, should be done, because joint replacements are quite successful in these patients. Clinical outcomes after, for example, total knee replacement, at 1 year most patients get about 120 degrees or more movements. At 10 years, 95 to 100% joints survive. At 20 years also, the survival is about 80 to 85%, which is quite sufficient for most patients. So once you transplant a knee joint in an elderly patient like 60, 65, then it is likely to stay with him for the rest of his life with a pain-free knee. It gives immediate pain relief to the patients, and most important, it improves the quality of life of these patients who can do activities of daily living on their own. It is now possible to do both knee replacement in a single sitting in selected patients who are medically fit, because it offers several advantages of single anesthesia, single time hospitalization. It is about 20 to 30% more economical and so on. But when you talk of total knee replacement with a patient, there are still several myths that are associated with it, and patients are very difficult to convince about the joint replacement surgery because they feel it's not a successful operation. Atal Bihari Vajpayee's operation was probably not successful. It's an expensive operation. My body may not accept it. The life of the joint is very short, and many people fear that they may not be able to walk again. Abhi to kaise jaise chal lete hain, baad mein shayad chal bhi na paye. You know, those are the common things that are told. But present and past TKRs are very different. In the past, when I learned total knee replacement in England in 1987 to 1990, we used to take 4 to 6 hours to do one single knee replacement, which now we can do in about 40 minutes or so. Recovery time used to be 6 months, now it is less than 6 weeks. Previously, we used to use at least 4 bottles of blood with each knee replacement. We hardly use now any blood in even bilateral total knee replacement. So there are lots of blood preservation techniques that are now known to us, and we employ this. Pain used to be a major complication after knee replacement, and now with very good anesthetists around, we have a lot of pain management tricks that they use to relieve pain, and most patients go home in 3-4 days time walking without much pain. Hospital stay is also reduced, and now these joints can last for about 25-30 years, which is quite big for the artificial joints. The major concerns in joint replacement surgery used to be restricted activities, limited lifespan, morbidity after surgery, high cost, and myths associated with all these have been addressed in the recent past, and joint replacements in deserving patients is quite a viable option. Pain is the biggest fear in the patient's mind about total knee replacement, and that's why they do not want to have the surgery. An adequate post-op pain relief gives a better outcome in these patients, and hence we take a lot of efforts in relieving pain after surgery by using multimodal analgesia, by using local infiltrative analgesia in the wound, using epidural infusion or patient-controlled analgesia, etc., in these patients. And believe me, more than the technique or the type of joint that you put, we have to address patients' problems like pain, blood loss, early rehabilitation. Then only we can make our patients happy. Otherwise, only surgeons are happy, patients are not happy. There are now newer joints that are available. One is a gender-specific knee, where we have special knees for females because they have smaller and different anatomy than males. Although outcomes may not be very different, but that option is available. We also have high flex knee where one can bend the knee fully and even can sit in cross-leg position. We have now customized knees for different shapes and sizes for each patient's knee. And we also have now coated knee that looks like gold, and that's why they are known as golden knees. We use patient-specific instrumentation for our patients, which gives very accurate fitting and especially accurate cuts for improving the outcomes. It was realized that some patients are not happy after joint replacement. Even their surgery was quite good, post-operative X-ray was good, there is no infection, nothing, but patient used to have pain, especially after 3 months. It was realized that some of these patients have very micro hypersensitivity to metal, like artificial jewelry, for example. These implants are made of cobalt chrome alloy, which is nickel as well. So this is similar to artificial jewelry. Some patients have obvious allergy to artificial jewelry where you can't use this implant, but many patients have very minor allergy which is not known. So it was realized that metal hypersensitivity syndrome was responsible for their pain, and hence now these implants are coated with special material to prevent hypersensitivity syndrome in these patients. And if you coat a normal implant with titanium niobium nitride, it gives a golden hue to the prosthesis and it looks like gold. That's why it is golden knee. And it's quite a catchy thing, especially for females. They like it and easily volunteer for the surgery. So it's a marketing tool as well. But it is useful because you avoid the metal hypersensitivity syndrome. Secondly, by doing that, the surface of the joint becomes even smoother, and hence the friction between the plastic and the metal is reduced, and hence the life of these joints is also enhanced. Previously, these joints used to cost about 3 lakh rupees each, only the part. But since our Prime Minister Modi ji has come and he has regulated this market, the cost is about 75,000 only, which is 15,000 more than the normal joint. Unfortunately, some companies have to wind off and go, but still there are a couple of companies who are still selling these products. So if anyone going for joint replacement asks for this coated implant, they are now quite affordable and good. Those patients who have limited joint disease, where you can put unicompartmental or partial knee replacement, which gives good result in selected patients. So what we have seen in last 30 years, improvements in total joint replacement is changes in practices. Especially we now know much more about how to do knee replacement much quicker through smaller incisions with better pain relief, prevention of blood loss during surgery, early rehabilitation and so on. Improvements in prosthetic design and instruments have been happening. We also use robots sometimes in doing joint replacement, but in orthopedics especially, robots are not that useful because, as Dr. Nagpal says, robot is useful in places where a normal human being's hand cannot access, but in most orthopedic surgery it is not required. So we rely on our muscle power and brain more than robot. better understanding of the procedure and optimization of cut. This is my last slide, and I follow this pyramidal approach in treating knee osteoarthritis. The most important part is education, counseling and dietary advice, especially if patients are overweight, and reassurance. They should not lose heart that they have got osteoarthritis. Somebody has put a label on them that you have osteoarthritis. It's not a dreaded disease, one can live with it quite successfully. Teach appropriate exercises and joint mobility and muscle strength. Teach joint protection technique and give them necessary braces to wear, especially during walking, etc. Simple analgesics occasionally for pain relief and physiotherapy, etc. Sometimes intra-articular injections, nutraceuticals, joint lavage for patients who have blocking in the knee joint, and surgery should only be reserved for end-stage arthritis where everything has failed. It should not be your first option to treat each and every patient of knee pain with total joint replacement as some people do. So I thank you for your attention.
Thank you very much, Dr. Raju Vaishya, for such an excellent presentation. Truly said, it is not a dreaded disease, and we must avoid NSAIDs for more than 10 days and unnecessarily injections, more than 2 or more than 3. So the house is open for questions and comments. Dr. Carlo.
That's very fascinating, very nice and detailed talk. As I could gather, sir, 86 years couple, then 93 years couple. You completed yourself. So they were couple.
Can I give you a little background information about these?
Yeah.
This 93-year-old gentleman was my father's patient in Gwalior. He was principal in a college there, and his son used to be my student in Gwalior Medical College. He is an anesthetist. So one day he called me and said, "Sir, father ka knee replacement karana hai." Now they live in Bhilai. I said, "Okay, le aao." Bolta hai, "Sir, wo 93 hai." So I said, "Oh, any problem?" "Sir, koi bimari to nahi hai." I thought he is hiding. So I said, "Okay, you bring and let me see." When he came, he was fully alert gentleman and no history of any drug taking except for mild hypertensive, and we could not find any disease in him. But still I was very hesitant to operate on him because of his chronological age. So I asked him, "Uncle, why do you want this surgery?" He said, "I used to play with Dhyan Chand, hockey, and I used to do horse riding, which I am not being able to do now." So I said, "Okay, what are the other reasons?" "I know I can live up to at least 100 years. Second, and that's why I don't want to live in this pathetic condition anymore." So there was no reason why I should not operate. So I said, "Okay, I'll try one knee. If there is no problem in anesthesia, I'll do both knees." So I could do both knees without any problem. And he was discharged like a normal patient and was very happy. But to my surprise, after 6 months he sends his wife, who was 86, and says, "Inka bhi kar dijiye." She had MI also previously. So then I had to do her both knees, and that's how he became the oldest gentleman who had bilateral simultaneously knee replacement under single anesthesia. And these couples, 93 and 93 and 86 became the oldest couple to have.
The couple on one side.
Yes.
What about living relationships?
Second marriage, almost equal to second
Any
marriage.
Go into their personal lives.
Any girlfriends? Anyway.
But this gentleman lived up to 99.5 years.
Sir, about Indian and Western toilets, what do you prefer and what do you advise?
See, if you have any knee pain, then you should avoid Indian toilet. But if you don't have knee pain, you can use Indian toilet because in deep flexion there is very high friction between the tibial and femoral condyles and patellofemoral joint, and these patients can wear off their cartilage very fast.
So prior to pain condition,
You can use Indian.
No, I am saying, is it a protective element in Indian toilets?
Indian toilets are quite good actually for hip joint, because normally when you sit on chair or commode, only part of the hip joint in the socket moves, not all the joint, and that's why the Western people have very high incidence of osteoarthritis of the hip, which we do not have. But due to this habit, we have much more higher incidence of knee osteoarthritis compared to Western population. So it's a balance.
So non-steroidal anti-inflammatory drugs, you said not to be combined too much. So there are so many combinations available.
Yes.
What about them?
Combinations are much more harmful. If you have to give any drug, give them in isolation rather than in combination. There are now at least some companies have 3, 4, 5 things mixed together. So I don't know what happens to the potency of the primary drug.
I would drive your attention to your statement that 10 days you can give them SOS.
Yes, correct.
SOS is a very big term.
You have to teach your patient that this is very harmful.
वो किसी ने कहा जी आपका तो कहते हैं बस दो बारी पीता हूँ जी, एक तो बारिश होती है तब, एक जब बारिश नहीं होती तब. So SOS is like daily.
No, not daily. I mean, you have to. Problem is most of our patients come from far off distance. They are not living nearby. तो अगर आप उनको ये ऑप्शन नहीं देंगे तो वो बार-बार तो आ नहीं सकते. तो आपको एजुकेट करना पड़ेगा.
Sir, about haldi.
Yes.
Kachi and pakki.
Yes.
How does it differ?
Oh, I don't know kachi pakki ka. But
Kachi haldi, pakki haldi.
But one thing is sure कि जितना हम खाने में खाते हैं, that is not sufficient to treat pain of knee osteoarthritis.
Like a ginger ना, कम से कम कच्ची.
जैसे कि आप एक हल्दी की गांठ खा सकते हैं ज़्यादा से ज़्यादा, पर एक कैप्सूल में आपको 10 हल्दी की गांठ के बराबर कर्क्यूमिन मिल जाएगा. And curcumin has several effects. It has found to be very potent in CA breast and CA prostate, especially immunomodulator, arthritis, cardiac disease, and there are more than 6,000 publications in PubMed on curcumin extract. I was amazed.
Sir, I have to ask a specific question. I am 72 years and I am going to
Don't look like something.
I am going to have pain, osteoarthritis right knee. What is the use of a lot of drugs available like glucosamine, diasterin, there are a lot of amino acids available. A lot of these things, how much they affect the knee joint?
Yeah. I have briefly mentioned about these. These are not drugs, first of all. These are nutraceuticals. Glucosamine and chondroitin sulfate was being used for almost 20-30 years in the past, but their efficacy has always remained doubtful. So they are almost going out of fashion or from the market. The better nutraceuticals that are available are curcumin, collagen peptide like Colaflex type drugs, rosehip extract, and there are various types of fish oils that are available. If you are non-vegetarian, you can take.
Sir, there are a lot of expensive, amino acids available. They say these are also good.
I mean, I didn't find any study in which amino acids have been used for knee osteoarthritis. But in market you will find thousands of things for such conditions which are not curable.
Thank you.
Sir, we have a lot of joint replacement people in our household nowadays. You showed a beautiful chart where you showed 5-year success, 10-year success, 15 years, 20 years. When they fail, how do we know that it has failed? What are the problems with the failure of a joint replacement?
Failure of joint is reflected by first patient's symptoms. The most common symptom is pain. Then gradually patient get inflammation. Patient's prosthesis can become loose, so they become unstable. And if they become very loose, sometimes there is periprosthetic fracture that happens. So it's a slow process, doesn't happen in one day. If you have persistent pain after knee replacement after a few years, or let's say 10 years or so, it must be investigated.
So thank you for a lovely talk on the osteoarthritis. I'm also 72 years old, and I have got my knee replacement about 3 years back.
Right, sir.
So I am comfortable after knee replacement.
Great.
Do regular exercises I have been advised. But what are the long-term precautions and prevention I should take post knee surgery?
Right. Knee replacements are like any other artificial things like car, etc., expensive car. You have to take care of it. The most important thing that you should not overburden these knees by doing high impact exercises, for example, intense running, jogging, or trying to force this knee. If suppose your knee cannot flex fully, if you try to do that, it puts a lot of stress on bone cement interface, tend to fail. Keep your body weight under control, keep doing your quadriceps and hamstring exercises. These are the common precautions. It has also been seen that patients who take bisphosphonates like alendronate, etc., tend to have longer outcome after joint replacement because their bone strength remains good to hold the prosthesis.
Without osteoporosis. If you have no osteoporosis, even then you can take
First is steroid, and then at the same time you can inject with hyaluronic acid. Because if you give hyaluronic acid in an inflamed joint, it is not going to work. Same system.
So after PRP, what are the restrictions for the patient? Like immobilization, take complete rest in bed for 3-4 days?
After PRP, the only restriction is to ask the patient to put ice because some patients have pain. Second is do not take non-steroidal anti-inflammatory drugs.
How long?
For at least 2 weeks. Reason being that these are anti-platelet drugs, right? They suppress the platelet and you have injected the platelet, so their efficacy will decrease.
Even exercise of the knee joint is not allowed.
No, you can do
You can do.
Any other questions? Okay, I would then request Dr. R.K. Wadhwa to summarize the CME for us.
We had an excellent presentation by Dr. Raju Vaishya, and the main take-home message was that osteoarthritis of knee is not a dreaded disease. We should not fear it. We must go by the stepwise approach to osteoarthritis knee joints, and the use of NSAIDs should be minimal. At a time 10 days, and after that once in a week or once in 10 days or 15 days, and too much injections should be avoided.